welcome everybody. We got the Welireg medication, the Belzutifan medication. The experience that we have is 3 years on clinical trials, and about a year now, almost a year, like 9 months, the drug has been given in many patients out of clinical trials. I understand that many of us have a lot of questions, and I will try to cover as many as I can. Let me try to make a small introduction at the beginning so that I try to answer several overlapping questions at once. The dose of the Belzutifan that we use is 120 milligrams continuously without breaks daily. We don't know if higher doses are going to be more efficient. We don't know if lower doses are going to be less efficient. We don't know if the medication has to be given continuously and forever and for a lifetime, or if the medication can be given intermittently. We don't know if the tumors bounce back after the medication is stopped, although it doesn't appear to be the case from a lot of investigators' personal experience with patients. We don't know if they increase, how long does it take to increase. So there are many things that we do not know about Belzutifan, and all these things that we're going to try to answer them as part of well-designed clinical trials over the next 3 or 4 or 5 years to come. So one of the things that I would personally ask you, and the Alliance will ask you, and I ask you this on behalf of my colleagues in many VHL clinical centers, is please participate in these multi-center trials so we know how to use efficiently and optimally this medication so that we can actually answer a lot of these questions that you are very thoughtfully and correctly answer right now. Given this limited clinical experience, I'm going to try to go one by one the questions and try to address some of the problems. So I have question 1. With patients with multiple lesion cysts or tumors, how effective is Welireg? Do patients need to be on the highest dose for it to be effective? I cover the doses of Welireg. Welireg shrinks tumors and shrinks also cysts. In my personal experience, it appears that it shrinks cysts and solid component proportionally in the hemangioblastomas, not so much in renal cell carcinomas, but we notice that it reduces the size both of solid tumors and the cysts in the hemangioblastomas, in the renal cell carcinomas, and in the pancreas. So yes, it affects both solid component and cystic component. We don't know if there is a specific dose that the solid component or the cystic component are affected preferentially. Again, the only dose that we're using is 120. We do know from clinical studies that has been done that even the double dose of 120, like 240, is well tolerated. We do not know necessarily is more efficacious. We're trying to go find out this one in clinical trials. Question number 2, Belzutifan is undoubtedly a game changer and desperate need on that. But, and there is a big but, the game isn't changed outside the United States without approvals from other medicines and regulators. So what's the VHL Alliance actively is doing to ensure that other countries and medicine regulators accelerate their approval, and so on and so forth. So what are we doing for international coverage of Welireg? So the VHL Alliance sponsor the trial and ask patients to come to the trial that approve the FDA medication. We do not have influence on regulatory agencies in other continents and in other countries. What we do, though, is that we work with the VHL alliances of other countries to inform the patients, to give the patients clear understanding of the value of the Welireg, and to actually help them to present the value of having Welireg get into their country to the regulatory authorities. There are continent regulatory authorities like the EMA for Europe, and there are country regulatory authorities. So we cannot apply to these authorities. The manufacturer of the medication, Merck, is applying to these authorities, and the patient organization in these countries lobby in favor of the approval of the drug. We help the patient organizations as much as we can. For example, this morning, as part of the Alliance, I organized and I had a seminar about the value of the medication, how to treat optimally VHL these days in the country that I was born, in Greece. And we think that we enlightened a lot of people and provided them a lot of ammunition. We're not allowed to talk to the manufacturer of the drug, and we're not allowed to apply directly. So we can do anything we can to our power to support the expansion of the use of the medication in other countries. Can use of Welireg be curtailed after tumors have shrunk? As I said before, we don't know this. We don't know if stopping Welireg will keep these tumors down and for how long, or if these tumors are going to come back. These are excellent questions that we're going to try to answer in upcoming clinical trials. I would say anecdotal evidence says from patients that actually for one or the other reason we had to stop the administration of Welireg, that the tumors are not mushrooming back. They are not increasing immediately back. How long that this is going to take, and if they're going to have a faster growth rate when they come back, we don't know if this is open for new clinical trials. Long-term reproductive effects. Will this be a lifetime medicine? How long does it stay in the body and continue to work on medicine stop? The medicine does not stay in the body. The half-life is approximately 24 hours, and that's why we take it once a day. So after 3 or 4, the maximum days, the Welireg, the medication, is not in the body anymore. We don't know the long-term reproductive effect in males or females. It may be none. And it's very possible that it's been none, but for the time being, we do not know the long-term effect. So what we recommend, what I personally recommend, because there are no guidelines about this, my patients, if they're males, is to preserve sperm. If there are females in the reproductive age that they are interested to have children, out of an abundance of caution, I advise them to cryopreserve eggs in case that they need to use them later on. I do not want to alarm everybody. It is very possible that it does not have any long-term effect in the reproductive capacity of males or females. But since that has not been verified yet and we're not absolutely sure, I take the safest and more conservative way when I counsel patients. Could this medication potentially cure other vascular tumors, non-VHL, low-grade pilocytic astrocytomas, or it's specific to VHL only tumors? No, it could potentially cure other tumors. And now Belzutifan is actually in many clinical trials. It is tried in combination with classic chemotherapy, with immunotherapy, triple combination of immunotherapy, chemotherapy, and Belzutifan in several other tumors, primarily in renal cell carcinoma, but also in other tumors. So the jury is out. We haven't seen the total capacity of the Belzutifan. We saw actually the first evidence of its effectiveness in VHL disease. And this is, as we say in the VHL Alliance, one more evidence that by studying VHL and understand the biology of VHL, we may actually cure or have an impact in cancer generally. Can you live a normal life long-term while taking VHL? Yes, you can live a normal life while taking Welireg, I'm sorry, not VHL, Welireg in long-term. It is a very well-tolerated medication. The only problem is anemia, and let me expand on this one. The next question is, do the low hemoglobin levels and fatigue side effects diminish or increase over time? So what is happening with the anemia of the VHL, the Belzutifan, is that anemia is something that's expected in a patient that's treated with Belzutifan. The hemoglobin, the hematocrit decrease. Now, I have been amazed, and many of us have been amazed on how well tolerated is this anemia and the decrease in hemoglobin and the hematocrit. So people do very well with significant drop in the hematocrit and the hemoglobin. We can see hemoglobin levels of 9.5 and 10, and hematocrit of 30, and this is very well tolerated. If they drop lower than that, then patients may have fatigue and headaches, which are the most side effects. The ways to treat this is to reduce the dose of Welireg, but again, we don't know that if the reduced dose is equally effective, and it may be very well, stop Welireg for a while, or administer erythropoietin. Also, if we actually look over time, the hemoglobin levels and the hematocrit come back. If we don't correct it with erythropoietin, they improve over time. They do not normalize over time, but they improve over time, and eventually they stabilize around a hematocrit of 30 or 29 to 31. About 10% of the patients that they take Belzutifan require treatment with EPO, but the majority of the patients adjust to this anemia over time without requiring the treatment with EPO. Question number 8, are you seeing any greater decreases in hemangioblastoma tumors in the brain, the spine with Welireg? I assume that that question means is there is a preferential effect in the hemangioblastomas of the brain versus the hemangioblastomas of the spine. We haven't seen any clear difference between these hemangioblastomas. We have seen responses in hemangioblastoma of the brain and the spine, but again, these were only 24 patients in the trial. They have hemangioblastomas, and we need better numbers and more numbers to understand if there is any difference between brain and spine. And primarily, we need clinical studies and biochemical laboratory studies in order to understand what's a biomarker, what will tell us that this person will respond to Belzutifan versus a tumor that's not going to respond to Belzutifan. For the time being, we don't have any clear biomarker. Question number 9, when should I start taking it? Let me answer this question later on, because I will actually close with some clinical scenarios about Belzutifan. I think you need to discuss with your doctors when we should start taking it. There is a very complex response to this question, but I'll come back to this. Question number 10. Will Welireg be a medicine we have to take continuously, or sometimes we may be able to take intermittently? Is it safe to take it long term, like over the span of years? So we do not know the very long-term effects of Belzutifan and Welireg. We have studied for 3 years, going to the 4 years right now. We do need long-term studies to see what the potential side effects may be. It's a very well-tolerated medication. My guess or bias, if you want to talk about this, is that it was going to be a very well-tolerated medication over a long period of time. If we have to take it continuously, intermittently, in lower dose, in higher dose, if the tumor progresses, should we increase the dose? If the tumor does not respond to Belzutifan, should we increase the dose? If the tumor shrinks, should we stop it, or should we just decrease the dose? All these are completely unknown questions. These are excellent questions, but these are completely unknown questions. And the only way to study these questions, to answer these questions, in well-designed clinical trials that we are actually designing, we're implementing right now, and then I'm going to ask you to participate, and they will take care over the next 3 to 5 years. So in 5 years from now, we'll have some documented evidence-based answer to these questions. Question number 11, what are the suggested actions to treat anemia caused by taking Welireg? So the ways to treat this anemia is, one, to stop the drug for a while. And again, we don't know if this is bad. It may not be, it may be good. The second one is to reduce the medication of the drug. The third one is to give a transfusion, which is my least favorite. And the one that I favor is to take erythropoietin. The label of the drug says that they do not advise to administer erythropoietin. It does not say they should not administer erythropoietin, the healthcare providers. This is a kind of a defensive, if you allow me to say, statement, because erythropoietin has been connected in very old studies in women with breast cancer to adverse outcome overall in their tumors. A lot of us are very skeptical about the studies. I do not think that they apply to renal cell carcinoma and to hemangioblastoma. There's a lot of basic science research that has been, that followed these initial clinical observations. The consensus right now in the field is that there is no contraindication in administering erythropoietin in cancer patients. Although this has not been formally suggested, I do not have any problems to give erythropoietin or darbepoetin, the RNSP, to the patients that I treat. I think that the VHL Alliance is going to organize over the next months a conference between stakeholders, and I think we're going to issue a consensus statement about the use of erythropoietin in the case of anemia that's caused by the Belzutifan. Question number 12. Which doctor is responsibly knowing when you can begin the Welireg and monitor your health? Endocrinologist or neurologist? Well, it depends who is the doctor that really takes care of your VHL disease. I think that the people have to go to centers that they have experience with the VHL disease, and we have designated clinical care centers and comprehensive clinical care centers. If the neurologist is the one who actually takes care of the patient, or the urologist or the endocrinologist, this is the one who should administer the medication. My bias and preference is I'm a medical oncologist, and I am a coordinator of the care of all my VHL patients, is that a medical oncologist preferentially should give this medication, because this medication, even if it's so well tolerated, classically is considered a chemotherapy. A neuro-oncologist can also provide chemotherapy, but I should admit there are endocrinologists in the field that they're very well versed in VHL disease and do care for a significant number of VHL patients. I think that a person who is familiar with the drug, comfortable with the drug, knows how to administer targeted therapy / chemotherapy, and can actually counteract the side effects of the drug like the anemia, should administer this medication. So I would say ask your physician if he or she is comfortable to give this medication. If they're not, find a physician who is comfortable to provide the medication. Question number 13, when will VHL children be eligible for this medication? It's a very good question. So far, the medication has been approved for adults age 18 and older. The studies about children are designed. They haven't been opened yet, as far as I know. They are under planning right now. It has to be tested in children with regards to primarily safety, not efficacy. And after this, it may be approved for children. I tend not to provide this medication to children, not only because, I mean adolescents and people less than 18 years old, primarily not because it's not legal, essentially hasn't been approved, but I do not know what the potential side effects in the developmental phases that the adolescents are going through very formative years. So I would like to see more data about this. Number 14, is it possible to prematurely begin the Welireg treatment, meaning starting before actually it needs sign or tumors, signs of tumor growth, or there is a lack, or in the case there's a lack of alternatives? So goes back to the question number 9, when should I start taking it? So let me try to approach this. We know that Welireg shrinks growing tumors and established tumors in the renal carcinoma area, neuroendocrine tumors of the pancreas, and hemangioblastomas. We should not use Welireg for prevention of the tumor formation. We do not know if Welireg can work as an adjuvant therapy, like after we take it out the tumor, should it prevent the new tumor? So Welireg should be applied when it has to be applied for growing tumors. We would like to start when the tumors are not at a point that provide that generate significant symptoms in the patients. Like we would like to do that not in hemangioblastomas that are already given headaches to the patient and they probably are very much grown up. We would like to know that not when a tumor, the renal cell carcinoma, is 3 centimeters plus. So we have guidelines when to interfere surgically with these tumors. So the tumor is significantly more or even more than 3 centimeters. I think this tumor has to be operated. So there's a question later on what a tumor of 4.5 centimeters should be done, how should be treated. And the answer is it should be treated with surgery. In the growing tumors in the kidney, we can give Welireg. It is reasonable to give Welireg. I avoid to use the word should, because it is a choice of how to approach the clinical situation on an individual basis. But on a growing kidney tumor, we may give Welireg. When I will be more inclined to give the Welireg, if the new partial nephrectomy, we know that is going to increase significantly the creatinine of the kidney. When the creatinine is already increased, and we know that the next surgery maybe push the person over to dialysis. Would I give it in a relatively young guy who has multiple tumors bilaterally? Yes, probably I would give it to see if it can shrink these tumors back. I would not give it to somebody who has a 3.5 centimeters tumor or a 4.5 centimeters tumor. This person has to go to the OR. When do we treat the tumors for the pancreas, the neuroendocrine carcinomas? Again, very few data for it, but I would apply the same rule. When I have a growing neuroendocrine tumor in the pancreas, I would try to prevent or delay Whipple surgery by administering Welireg. When would I treat somebody with hemangioblastoma with Welireg? When I have a growing tumor, because tumors may be sleeping and may be dormant in hibernated state for a long period of time. So I would prefer to apply the medication in a growing tumor before it produces significant complaints and symptoms depending on its location. Because when the patient has already big tumor that obliterates the space in the brain and causes a lot of headaches and neurologic symptoms, it's not time for Welireg, it's time for surgery. Should we treat tumors in the hemangioblastoma area when they're very small versus when they're growing more? Nobody knows what's the optimal timing. Are smaller tumors more likely to respond than bigger tumors? We don't know this answer. Are stable tumors, independently of the size, more or less likely to respond to growing tumors? We do not know this answer. So again, these are clinical questions that we are acutely aware of and that we're going to try to answer in well-designed clinical trials. Question number 15. Considering there is not an end game for the treatment, would it be better to consult with your collective VHL team of doctors before beginning this treatment? Categorically, yes. I wouldn't begin any treatment unless I discuss the reason to start it, the end point of the treatment, what I am trying to achieve, how, if, and when I will stop the treatment with my physician. Again, we have a limited experience and a very efficient medication. I think that we need to approach of how to use it in a very organized way. Until then, many patients will need to be treated with the medication without having a complete picture, and then the game of how to treatment has to be discussed on the individual basis with their physician. Number 16, how does it affect infertility? And I answered this question, they mean fertility before. We don't know if it's affected, but we try to be very cautious. How is this used long-term? We don't know how long-term it has to be used. It is very well tolerated long-term, as it's tolerated short-term, I mean long-term up to the 4 years now. We don't know if it has a very long-term side effects. We need time to decide about this. So I think that we need to try to focus our thinking, our questions of how to be used best over the next year, 2 years for all of us, and I mean patients and care providers. The very long-term outcomes of Welireg will come in very long term time frame. Number 18, does the drug affect your way of living? If so, how much? Again, it's a very well tolerated medication. Only 10% of the patients had significant side effects, and the main side effect was anemia, which we covered before how I would treat it. I would treat it essentially with erythropoietin. I wouldn't give blood to the patients. If erythropoietin does not work, I may stop the medication for a while. Allow me for a second to say an important detail caveat here regarding the use of erythropoietin. Welireg may not only suppresses the red blood cell formation, but also may reduce the absorption of iron from our gut. And this absorption of iron stores in the bone marrow are required and necessary for the formation of red blood cells. So one of the things that we need to make sure that happens is that the patient is not iron deficient. That's why we have to monitor also the iron levels, ferritin, iron, and total iron binding capacity in the blood of the patients that they take Welireg and they are anemic, or even if they are not anemic, to make sure that they are not iron deficient. Particularly young women that they are menstruating, they lose a lot of blood and they're losing iron, and therefore a lot of young women are borderline iron deficient all the time and very normally, and the treatment with Belzutifan, it may actually tip them over and they become clearly iron anemic. To add here more, I don't treat, and people should not treat really, again, I shouldn't use this word, but I don't treat iron deficiency with iron pills through the mouth. The absorption of iron through these pills is minimal. A significant iron deficiency that causes or contributes to the anemia of Welireg or any type of anemia should be corrected with intravenous administration of iron. Number 19, what if any longer term side effects or implications have become known? Nothing that we know than we did know from the beginning of the end of the study last year and the publication of the paper in New England Journal of Medicine. Again, very well tolerated. Some side effects, nausea, pain in the joints, a little bit increase in creatinine, a little bit increase in glucose, dry eyes. Some people complained of constipation. Some people complained of some shortness of breath. The major side effects is feeling weak or having headaches because people are seriously anemic, and this is happening in less than 10% or about 10% of the patients. Question number 20, safety around dentistry or other medical procedures unrelated to VHL. It's a very good question. Excuse me. If the patient has to undergo operation in dentistry, we stop Welireg 3 days before, and we started 3 or 4 days after the procedure. This is extreme caution. We do not know for sure that Welireg impairs the ability of healing or increases the risk of any type of operation. Other TKI VEGF inhibitors like pazopanib and sunitinib impair healing, but the mechanism of action is different, and Welireg reduces VEGF and PDGF, but doesn't stop them to the degree that the VEGF inhibitors stop the action of VEGF. So it is possible that Welireg does not affect healing. So prevented, I mean, out of a lot of caution, we stop it before and for a few days before, and we'll continue to stop it for a few days after the operation. But it's not any hard data that says that this has to be done. In surgeries, not procedures, but surgeries that require anesthesia, the major reason to stop the Welireg 3 days or 4 days before the operation is that there was a thought that there is a possibility that the Welireg interferes with the exchange of gases during the anesthesia, the breathing, because it clamps down here. There is a possibility that pushes people a little bit towards hypoxia. And in the case of anesthesia, they didn't want to have this complicating factor, particularly because we didn't know how to deal with this complicated factor. So therefore, out again of abundance of caution, that has been stopped 3 or 4 days before an anesthesia procedure. Question number 20, safety around, oh, I'm sorry, I answered this one. Question 21, tips for overcoming the fatigue. Well, you need to make sure the fatigue, the hematocrit can be supported enough. If the fatigue is due to the anemia, the only way to overcome the fatigue is to correct the anemia. But remember, fatigue may not be only anemia. Fatigue may be deconditioning of the body. Sometimes fatigue may be depression. So you take Welireg, the Welireg hasn't worked yet as you expect to work. The patient may get a little bit depressed about this and they feel fatigue. And it's not real fatigue due to the drop of hemoglobin. It has an emotional component to fatigue. Fatigue can be due to changes in the thyroid function. So we need to check the thyroid function. So fatigue does not necessarily mean anemia. If anemia is present, particularly if the hemoglobin is 9 or less, then in this case, I think that people have to be treated with EPO or reduce the dose of Welireg. If Welireg causes fatigue independently of the level of the hematocrit, then I would reduce the dose of Welireg. But I would, in all cases, investigate the symptom of the fatigue as it is a symptom that may be due to other reasons other than Welireg. Again, thyroid function test, psychological condition, levels of glucose, mobility, deconditioning, pain sometimes that makes us to look fatigued, chronic pain. This is a complex problem and has to be addressed by the physician. Question number 22, it says not to touch the pills. Can the side effects of the drug be passed on to a patient via sexual contact? Absolutely not. You can touch the pills, you can caress the pills, you can play with the pills. This is not a toxic medication. The side effects of the drug are not passed through sexual contact and not passed through physical contact. It has nothing to do. This is not a toxic medication. I can't say that you know, more strongly. There is nothing to be afraid of this medication with regards to contact. There are classic chemotherapy agents, not all of them, that they're irritant with direct contact. That has nothing to do with Belzutifan and Welireg. Number 23. I'm starting Welireg tonight, May 23. I have a kidney transplant. I'm concerned about any long-term effects of the graft kidney. Is there any data on risk or on contradiction with rejection drugs like tacrolimus and sirolimus? No, there is not. People with one kidney can take Welireg. People that they have a transplant kidney can take Welireg. Now, with any type of medication co-administration with immunosuppressant medications like tacrolimus and sirolimus might have a synergy. So the levels of tacrolimus and sirolimus in the blood should be monitored, and the creatinine of the kidney should be monitored. We do not have a big experience with this medication in transplant people. A priori, there is nothing to actually forbid transplant patients to be treated, but we should be carefully and closely monitoring levels of tacrolimus, sirolimus, and creatinine during the treatment. My guess is that it will be well tolerated, but again, the experience is limited. Question number 24, my daughter is tube fed. She cannot take anything by mouth. Can we crush the medication? I'm not sure. That question stumped me. I don't know if we can crush the medication, but I promise to essentially ask the manufacturer if this is possible. I'm not aware of any liquid form, but I'm going to ask the manufacturer if it is possible, and I'll get back to you. You can email me personally. You can email to Josh, and we will answer this question of yours. A very, very interesting question. Question number 24. What is the state of use of Welireg for stabilizing the size for CNS hemangioblastomas? Can be used during the watch and monitor stage for lesions that are not ready for ejection in order to untap to stabilize, or are side effects such that Welireg should be the last resort? No, the Welireg should not be the last resort. The Welireg should be actually the first medication of treatment of CNS hemangioblastomas. Surgery should be the last resort these days. Again, we don't know if the small tumors respond better than the big tumors. We don't know if the growing tumors are more sensitive than the not growing tumors. If there is a hemangioblastoma that remains dormant for a long period of time, I would not treat it as it stands today, and that may change tomorrow with Welireg. If there is a growing hemangioblastoma, not just moving 1 or 2 millimeters, but if there is a consistently growing hemangioblastoma or significantly growing hemangioblastoma, so the trend is established in the growth of this tumor, then I would definitely consider Welireg before I subject this patient to therapy these days. And I would do this for both brain tumors and spinal tumors. We have seen great responses in the solid component of the tumors and the cysts. I have 20 patients right now treated with, for the reason essentially of hemangioblastomas on the central nervous systems, and we see significant responses in the both cystic and solid component. Question number 26, what is the longest observed period, I assume, for someone responding to the medication? We are told there are 3 months, that 3 months is the suggested timing, but does it take longer for some? I assume that the person who asks here the question refers to time to response. So it's a difference about time to responses. The Belzutifan takes a while to establish a response in the kidney. So we have seen kidney responses, shrinkage of the tumor in the kidney 6 months, 7 months, 8 months after administration of Belzutifan. So as long as the tumor does not progress on Belzutifan, I continue to treat the patient with Belzutifan. Lack of early response for the renal cell carcinoma does not mean that there is not going to be response in renal cell carcinoma. My personal experience and opinion is that the hemangioblastomas respond sooner to Belzutifan than the renal cell carcinomas. I have seen most of the responses within 1.5 to 3 months. Whether or not somebody who responds in 3 months will have a more durable response, whether or not somebody who does not respond 3 months will not respond or will respond with less durable response in the future, this is not known. But It is not, it's a medication that will take a while for the kidney to respond, and it may a little bit shorter, but still several weeks in the case of hemangioblastoma to act and to shrink the tumor. And this is exactly why tumors that they are very critical cannot need to be operated and cannot treat it with Belzutifan. Because if you have a critical tumor that causes serious symptoms in the brain, you cannot wait 3 months to see, or 6 weeks to see if the Belzutifan is going to work. And if it's going to work, maybe great, but if it's not going to work, the surgery is going to be much more messy 6 weeks later. And the same one is a tumor for a renal cell carcinoma, which is bigger than 3 centimeters. So we would start treatment in a growing tumor, and this is a general rule, before it reaches either the cutoff for surgery or produces significant symptoms in the case of the central nervous system hemangioblastomas. Number 27, is there any data on longevity? How long Welireg continues to be effective after starting the treatment? We don't know. We treated patients, I explained that we treated patients up to 3 years now, 3.5 years. The only thing I can tell you is that we have seen partial responses that after 3 years were turned into complete responses. So in a very delayed fashion, 3 years later, all of a sudden a tumor disappeared. In the same time, we had some people that they progressed in their diseases after 3 years. So after a 3-year period of time, we did see some resistance to Welireg. And this is where the whole discussion comes. Should we give it continuously? Should we give it intermittently? Should we take breaks? Do these breaks need to be dictated by the size of the tumor, or do they need to be formulaic breaks that we give the medication on a cyclic basis? And we work on design clinical trials to answer all these questions. So far, we had people that they are not 3 years, I'm taking back 4 years on Welireg, and they had the continuous response. But around the period of the time of 3 years, we did also see some progression of disease due to resistance to Welireg in a very, very, very small number of patients. Number 28, is the drug indicated for multiple bilateral renal cell carcinomas without metastasis? How to give the drug in India? So that's exactly, the Welireg is indicated for renal cell carcinoma non-metastatic, is neuroendocrine tumor of the pancreas, non-metastatic, and hemangioblastoma of the CNS. So yes, it's indicated for non-metastatic tumors. I don't know how people can get it in India. Has the drug, it has to be approved by the regulatory agents of the specific countries. Number 29, has the drug been tried in any older persons, and for how long? There is not a cutoff of age. There is a cutoff of younger age. We tried it in people more than 18 years old, but there is not a cutoff age for older people. I don't know what is the oldest person in the trial. The oldest person that I treated with the medication is 78 years old. I'm sorry, 68 years old. I haven't seen any worse tolerance of the medication in people that they are kind of in the 6 or 7 decade of life compared to the younger people. I haven't noticed any correlation of age with side effects. Number 30, can anything be done if a VHL patient normally has anemia and wishes to try the drug? I answered, I think, this question. The anemia may be due to many reasons. I would examine why a VHL patient has anemia, because it is not part of the disease. To the opposite, a lot of times they have polycythemia, erythrocytosis, a lot of red cells. If a VHL patient is anemic, I would actually try to find out what is the cause of the anemia. Is there any bleeding? Does the patient suffer from iron deficiency? Does the patient is on any other type of medication or therapy? So I would work up first the anemia of the VHL patient before I give them the Belzutifan medication. Number 31 is 5x4x4x8 times 5x6 tumor in the left kidney required surgery? Absolutely yes. Any tumor above 3 centimeters require surgery, I would not treat this patient with Belzutifan. Is Welireg effective for tumors in the brain and the spine? The answer is yes. Should someone with only one kidney take this medication? The answer is absolutely yes. There is no contraindication to take the medication if you have one kidney or if you have half kidney. Again, the creatinine should be monitored like everything else should be monitored when you take Welireg. What do we monitor? We monitor hemoglobin, hematocrit. We monitor general laboratory profile, but more concisely hemoglobin and hematocrit. We also monitor glucose and we monitor creatinine. I will stop here. I answered 32 questions. I hope I cover most of the questions that people have in their minds, but have few more minutes if something burning is in your mind to discuss it.
Dr. Iliopoulos, there's a few questions in the chat.
Can someone with seizures take Welireg? There is no contraindication. Seizures have to be controlled. I would actually say if the seizures are due to a tumor, there is a possibility that Welireg will be beneficial because the tumor may shrink or the cyst may shrink. So there is no contraindication not to take the Welireg if there are seizures. Is there any info about treating eye tumors with Welireg? Actually, this is where we have the least information. Now that we treat much more patients and we enter the data in databases, we'll accumulate some information about this. We did see responses in retinal hemangioblastomas. We clearly did see responses. Now, again, the number of the patients was very small, and therefore I cannot give you a percentage of these responses, but we did see responses in retinal hemangioblastomas, particularly in tumors, hemangioblastomas of the optic nerve, that there is no other treatment. I would definitely try Welireg for the tumor. So yes, I would, it hasn't been approved for retinal hemangioblastoma, but I would definitely like to treat a retinal hemangioblastoma, particularly difficult ones, with Welireg. How often do you monitor creatinine and glucose? I would monitor once a month. I don't think that these are values that they go out of control. I monitor hemoglobin and hematocrit every 2 weeks for 6 weeks at the beginning, so I get a sense of how low they are going to drop. But then I monitor the monthly basis if they stabilize. Small tumor in brain dormant, but aren't they always growing? I'm not sure what that means. This is a question from Mary. Tumors can be small, and if they grow, they're not dormant. If they're small and they don't grow, again, I said, I don't know if this is a good time to try Welireg because they're more sensitive to it or not. What about with someone with a lot of tumors in the pancreas? We're not bothered by the cyst in the pancreas. We don't see pancreatic insufficiency, either endocrine or exocrine, because of the cyst in the pancreas. Let the cyst of the pancreas be alone and don't bother about them. We don't care about serous cystadenomas of the pancreas. They're benign tumors. They don't bother us. I did have a patient that the size of a very benign cyst was starting impinging on the gallbladder, and it had to be removed surgically. kind of decorticated because of this anatomic obstruction. And I assume that I would have tried Welireg before surgery if Welireg was available. But Welireg is not approved for cyst of the pancreas, and we shouldn't, poke around with the cyst of the pancreas. It is approved for neuroendocrine tumors of the pancreas and growing neuroendocrine tumors of the pancreas that they are less than 3 centimeters for the hair of the pancreas. Should be treated with, not should be treated, may be treated by Welireg if the goal is to avoid Whipple's procedure. My son has had multiple surgeries in CNS and brain hemangioblastomas. We live in Australia. How do we get this medication at a reasonable cost? I don't know. I'm sorry. I feel very bad every time that I answer this question this way, but the only way to do this is to have the regulatory agency of Australia, India, Greece, of any other country to approve the medication for the specific country. You can help as patients by lobbying to the regulatory agency, to the government, to the representatives. If you want to actually contact the manufacturer and see what you can do, I mean, they may welcome it. We, as a VHL Alliance, were not allowed to actually even contact the manufacturer to help them approve the drug in a certain country. It's regarded as an ethical and conflict of interest. What about someone with lots of tumors since the pancreas? I answer this one. Is there any way for us to submit our scans data while using Welireg if we are not part of a trial? Using a special access program in Ontario, Canada, or the way to support further data research? Yes, understand and appreciate very much the question. I think that if you use it in a, if you're getting treated by somebody in a clinical care center, they should create their own database. We're in the process now to connect in connecting the different centers that they have a lot of patients, and we will have a collective database for patients. We'll also hope to open clinical trials very soon, and being part of the clinical trial would definitely help understanding the disease. But if you are treated out of a clinical trial, there should be either a connection of your doctor and some relation and communication of your personal doctor with the clinical care center, and we have a clinical care center, I believe, in Canada, or if there is no connection with this doctor, I mean, I think that they need to contact VHL Alliance and see if they're interested to create a clinical care center. I don't think that I see another question, Josh, unless I miss a big one.
No, I think you got them all.
Can you take a question over the mic?
Okay.
So in my family, we have an extended family with the disease, and there is one young lady and one young fella who both are starting a family, would like to become pregnant, and I'm afraid, and they both have active hemangiomas. So they're going to wait. Is it possible to use the Welireg and back off in between planned pregnancies? So you try to reduce it and then stop, have another pregnancy, and then restart.
Yeah, tough question. If we assume that Welireg does not affect fertility, I would say take Welireg and then stop it and become pregnant. I would prefer that they have the pregnancy first and take the Welireg afterwards. But you're bringing a bigger point. What's the relation of pregnancy with tumors and the CNS hemangioblastomas? If I have 3 tumors in my brain, am I allowed to become pregnant? It is not true that pregnancy necessarily accelerates the growth of the tumors. That was an old thinking. There are contradicting studies, but I think that if somebody looks very closely There is not a lot of data that supports. There is no data that supports that if you're going to become pregnant, the tumors are going to accelerate their growth. So if the tumors are small, I would say, it's an individual decision, but I would say become pregnant. And in 9 months, 10 months, we'll scan you again and see where we are. If the tumors are of worrisome size and a very worrisome location, and they give some early evidence of edema right now, I would say, maybe we should take Welireg first and then shrink the tumors. If there is only one single tumor, that it is the very worrisome one, the others are small, I would say, you know what? Let's take a surgery, take this tumor out, and then when you become pregnant. It's a custom-made approach. I think that this is where the clinical experience comes in. But one of the things that I would ask this relative of yours take into consideration is that there is a possibility that natural pregnancy may become a little bit difficult after they take Belzutifan. Again, this is an extreme caution. I do not know that for sure. I do not want to send waves of alarms, but we don't know what is the effect on fertility. We know some other medications, we haven't had enough data for this medication. So if I wanted to be extremely cautious, and the person says, no, I don't want to go for surgery, I want to take Belzutifan, I would say, freeze your eggs first, go to treat yourself with Belzutifan, and then do an artificial insemination. It's a question of how bad the tumors are. When are they supposed to be pregnant? When are they expecting to be pregnant? Is it something that they think in doing in 5 years? Something that they think to do now? It's a custom tailored approach.
Doctor, one postscript. I'm 71 years old after having had a series of resections over my life, beginning Welireg. I have 6 active locations of growing tumors. 5 of them have reduced within the first 3 months. The other one stopped growing. So it's just encouraging for anybody else out there that don't worry about age. As of now, I don't limit. I do work very hard to try to stay in shape. I think that's important, but it's encouraging.
I was going to say you don't look like 71. But I believe it's true. Yeah, absolutely. There is no reason to be afraid to take based on age. I'm sorry, if you don't mind if I ask, these tumors are hemangioblastomas? Are they in the brain or kidney tumors?
4 hemangioblastomas removed, 1 pheo removed in 1979. The hemangioblastomas were 1998, 2008, 2009, and last year, 2021.
But what are you taking Belzutifan for right now?
I just started December 20th. So yeah, and I have 6 other active locations. So they've all showed improvement in the first 3 months.
Great.
I would place more surgeries without a doubt.
Great.
And the other encouraging thing for everybody out there is you don't have to look forward to being my age and having tumors. Most of you will never see any more growth after age 60.
Very well said. Oh, there's another question. Could Welireg reduce pheochromocytomas? Yep, they can. The pheochromocytomas, very few in the study who had responses in pheochromocytomas. And out of the study, I can tell you from personal clinical experience, yes, it can reduce pheochromocytomas. Okay, it's 8 o'clock. Thank you all for being here. I hope that I helped a little bit with by answering all these questions. Thank you very much. Please contact Josh if we can help you more about specific questions that you have. And please stay tuned with the developments in Belzutifan and upcoming clinical trials to help everybody, each other. I think that the best way is to participate in clinical trials with this medication now.
Thanks so much.
Good night, everyone.